So let's begin with case number 54 here, which is about a gap between the front teeth. This case is important. We have to do it from Odell. What relevance it has for ADC exam is that it is one of those cases where you have multidisciplinary discussion of prosthodontic problems, how it can affect periodontium, and periodontitis, how it can affect the prosthesis, and how both can coexist. And patient can have a separate periodontal problem and a prosthetic problem. What should be a solution? What should be the treatment plan? Where you can think that a referral is required. So much you're going to grasp from this case, so much you're going to learn from this case. This case alone is one of those cases which there are plenty of such cases in Odell, which give you bulk information for about 20, 30 questions in the exam. So those chunky chapters, like which give you a lot of information, a lot of concepts, which you can apply to so many questions, are the golden mine, like where you can actually dig up a lot of information, use that in the exam. So this is one of those chapters from which, in fact, a direct question, a direct concept can be asked in the exam. That's how important, that's how relevant few of the Odell chapters are. So the ones that we are recording and the ones that have been shared on the website specifically target those concepts, right? So you're going to learn and enjoy this case so much. I enjoyed preparing it, and I'm going to enjoy teaching it as well, but it's going to be a gold mine of information. So 35-year-old man noticed a small gap appearing between two incisors. What is the cause and how can you treat him? This is a clinical picture, and ADC loves giving you pictures like that, where there's prosthesis, there's gap, there is marginal gingivitis, there's redness, and then because they make you think about the whole situation as a multidisciplinary case, not just like treat the gingivitis or treat the periodontium and just be done with it. You have to see what the prosthesis are, or what impact the prosthesis is having on this patient's periodontium, and how periodontitis is affecting, and what kind of prosthesis selection would you go for. So this chapter opens up and kind of gives you that thought process, which is totally required for answering SBQs in the exam. This is the stuff your SBQs are made of. So you should totally learn from these cases that this is how variedly and how widely your thought process should be going, and you should not be just restricting yourself with a chief complaint or a single approach, but rather would be taking a multidisciplinary approach for the patient's management. So the patient is concerned about the gap between a crowned upper right central and a lateral incisor tooth, and then noticed the gap about 9 months ago, feels that it has enlarged and that the teeth have drifted forwards and that the crowns are now loose. He has had no symptoms from these or any other teeth. He has mild asthma controlled with an inhaled steroid and a salbutamol, but he does not smoke. The patient is new to your practice. He attended his previous dentist regularly, going every 6 months, but now less frequently. The crowns are approximately 6 years old and were fitted to replace some unsightly anterior composite fillings. The patient's anterior teeth are shown in the picture. What do you see and how would you interpret the appearances? So the upper right lateral incisor is slightly rotated mesiolabially. It has slightly rotated towards the labial aspect mesially, and the central incisor distolabially. So this has rotated distally towards the labial aspect. Now there is recession on both the central incisors and lateral incisors. As you can see, there is slight CEJ that you can see. So there is recession. Of course, you can see the CEJ. Here the CEJ is pretty low. So there is remarkable recession over the lateral, right? So the gingival tissues have some rounding off the margin and marginal gingivitis. There is loss of stippling and contour. As you can see, there is diffuse redness. And also there is loss of stippling, the shiny appearance, and little sogginess to your gingiva. These appearances suggest that the labial drifting as a result of loss of periodontal support. Pocketing is probably present, even though it is not obvious. So now this is also known as your pathological migration, right? If periodontium has damaged and there is incomplete periodontal support to the teeth now, sometimes they can drift, and that is known as pathological migration or pathological drifting. It is also one of the questions in your perio files, where 1,000 or past papers I don't remember, but there's this question in the perio file that what would be the first sign of aggressive periodontitis? And sometimes, before even you notice the radiographic bone destruction or pocket formation, the patient would complain of pathological migration or pathological drifting. That can be the first clinical sign. Like in this case, the patient is presenting to you with a complaint of gaps and drifting between the teeth, right? So upon external examination, there is no lymphadenopathy, no tail and joint signs. Two crowns, although prominent and rather light in shade, are under the control of lower lip associated with competitive lip seal. The patient has a broad smile and a moderately high lip line, so the lower lip is also creating some pressure on the teeth towards the palatal side. Now the oral mucosa is healthy. There is no caries, only a few amalgam restorations, but there is focal marginal inflammation and plaque lying interdentally. Metal ceramic crowns on the upper two centrals, they have good margins, but there is 3 millimeters recession palatally, and both teeth are grade 2 mobile. So you have palatal recessions on the crown teeth, but the margins are really good, and there is grade 2 mobility. So maybe the crowns are not responsible for the periodontal condition, but there is definitely some periodontitis, right? The further diastema is present in the opposing arch between the lower canine and the first premolar. That can be seen on the picture. We'll just look at that in a while. And the adjacent lateral incisor there would have grade 3 mobility. So incisor in the lower would have grade 3 mobility, and the canine and first premolar again has a gap. And the gap between the upper central and lateral is at least 3 millimeters. And on gentle probing of the area, there is profuse bleeding. So marginal gingivitis, there is recession, drifting up to 3 millimeters, and generalized gingivitis. The gingival tissue in that area is red and inflamed and has lost any contouring or stippling. There are deep probing depths on several teeth as well as mobility. So multiple teeth are actually having deep probing depths, generalized inflammation. Investigations, which include the plaque and the bleeding charts, risk factor assessment, and radiography are necessary. Detailed 6-point periodontal charting, including recording of your bleeding on probing, is required before and after periodontal treatment. Now let's look at the clinical findings again. As was described, the palatal recession is seen. On central, the labial side, the recession wasn't a lot. It was like about 1 millimeters. On lateral, on the buccal side, it was about 3 millimeters. There's a 3 millimeter of drifting here as well. And on the palatal side of the centrals, you see that there is marked recession. In the lower, you can see that I mentioned lateral is basically your grade 3 mobile as well. There is recession with the canine as well, and there is a 3 millimeters diastema between the canine and the premolar, right? So all the clinical findings are such. There is generalized gingivitis, and now they go ahead and take the periodontal examination, which would be like a bleeding on probing, mobility for each tooth, probing depths, plaque score. Everything was recorded and given in the chart. So sometimes ADC will also give you a chart, so you don't really not need to be a pro in reading the entire chart in detail, but you must know that the clinical attachment loss, if seen, if there is buccal palatal attachment loss. So clinical attachment loss is really important, especially when you see areas like 9 and 7 and 6 and 8, something which goes on more than 5. If you see a lot of area going more than 5 millimeters of clinical attachment loss, then that means it's a severe periodontitis, right? If it's less than 5, then it's moderate to mild. And if more than 30% of teeth are involved with such amount of attachment loss, then that would make it a generalized periodontitis. And if it's less than 30% of teeth involved, which would be less than 10 or say about 8, that would be your generalized, localized periodontitis, right? So the 30% formula applies to 32 teeth. So you can calculate the 30% for this. So that would be roughly about dividing 32 by 3. And that would be roughly 11, 10 or 11 teeth involved. That would give you your generalized periodontitis, right? So let's look at it. How many teeth are involved with clinical attachment loss more than 5? And this red circle means that they also have bleeding on probing. So that's pretty much like 1, 2, 3, and then 4, 5, 6, 7, 8, 9, and 10, right? So 1, 2, 3, and then 4, 5, 6, 7, 8, 9, 10. So that's precisely 10 teeth which are involved with severe kind of attachment loss, and others also have some attachment loss, which would be moderate in category, but that would be categorized totally as a generalized periodontitis and the stage 4 and grade C. Now, the staging and grading classification of periodontitis was launched in 2017, and since then we have been anticipating that ADC would use this terminology or would ask you to classify the periodontitis on the terms of staging and grading, but so far they haven't. In the last 3 years, they haven't asked the staging and grading classification. But for your knowledge, and maybe in the part 2, when you go for your part 2 examination, they may ask you this. So I will be giving you this staging and grading table. It is not a very complex classification. So staging is basically, it has got 4 stages. It mostly can be easily decided based on the attachment loss. If majority is 1 to 2 millimeters, it's stage 1. If it's 3 to 4 millimeters, it's stage 2. If it's greater than 5, then stage 3 or stage 4, depending upon how many teeth has been lost, or in addition, is it a complex condition, then probing depths are more than 6 millimeters, or if there is masticated dysfunction, secondary occlusion trauma, and there is bone loss which is going beyond the middle third of the root. If it stays up to the middle third, it would be stage 3. If it goes beyond the middle third, it would be stage 4. So based on that, you can pretty much think of it like it is the severity: mild, moderate, severe, and super severe, right? Earlier we used to have mild, moderate, and severe. Now it is 4 stages. Coming to the grading part. Now the grade is how severe or how rapidly progressing this is. Stage is like what the damage has happened till now, and the grading is how you think and how you can anticipate it to progress. So something can be really severe in staging, but maybe slow rate progression. That is why maybe in a grade A, slowly progressing periodontitis. Whereas in a certain case, it could be a severe one, or it could in fact be a mild stage 2 or stage 3, but a rapid progressing grade C, and that would require immediate attention and aggressive treatment. So I hope it's making sense to you that even grading is really important and staging is not. So staging has its own importance in the existing condition, but the grading tells you the future of the condition and how it can progress, what and how you can expect it to respond to the treatment, and how it can even affect the systemic health of that person. So if it's progressing at a higher bone loss over the years, then it goes to grade C. If it's low or moderate, it's grade A and grade B. And the grade modifiers or the risk factors which can increase the rate of progression is basically smoking and diabetes. They're the most important risk factors. So non-smokers and non-diabetic would have slow rate of progression, and smokers and diabetic controlled ones would be moderate, but heavy smokers and uncontrolled diabetics would be rapid rate progressive, right? So I assume that it makes sense to you. You don't really have to mug up all these tables, but just for your understanding, and I think if you keep revising this chapter, the staging and grading will eventually make sense to you. But please remember, this was launched in 2017. ADC has till now, in 3 years, not asked any of it, right? So we come to the conclusion of that it is your generalized periodontitis. It is your stage 4 and grade C. That means rapidly progressing, currently unstable. Periodontitis has reduced the bony support for the upper and the lower right anterior teeth, which have now drifted labially. Bone loss extends close to their apices, and they would have drifted further had they not been retained by the patient's own lip musculature. Recession is also the result of periodontitis, attachment loss. However, the pattern of periodontitis is unusual. The patient is only 35 years old but has severe localized attachment loss. Especially the molars and incisors show you the characteristic vertical bone loss. So if you look at the molars and the incisors, there is a characteristic vertical bone loss rather than the horizontal bone loss. You would notice the vertical angular defects. I hope all of you can make out when I'm showing you on the radiograph. These are your typical vertical or angular bony defects. I will talk about more, and I have actually talked about it in other Odell cases as well. And in the live perio classes, I will be teaching you all about the kinds of bone losses, which disease and what particular conditions you can expect what kind of bone loss, right? But you can make out here, at least on the radiograph, that it's an angular kind of bone defect, right? Not the horizontal bone loss. So what predisposes the patient to a localized attachment loss? So he might have generalized periodontitis because all of teeth are affected, but if you look at the attachment loss, clinical attachment loss, it's usually localized towards molars and incisors. So there is a genetic predisposition, poor oral hygiene, endodontic problems which lead to endodontic periodontal lesions, concomitant lesions, which we have discussed in the endophiles as well. And the root fractures can give you localized bone losses. Local factors like food impaction and diastemas also lead to the vertical bone loss, overhangs, poorly contoured restorations, high frenal attachments, oral piercings. They all can lead to localized attachment loss, recessions, vertical bone defects. Trauma caused by oral piercings, destructive habits, and self-inflicted injury. They all can lead to such localized attachment loss, whether in form of the bone loss or recession. Can any of these explain this patient's pattern of disease? Primarily, the incisors and first molars are involved. The pattern of localized destruction and the shape of the deep infra-bony pocket, that is another name for your vertical bone defect or the angular bone defect, right? They're all same. Angular bone defect, vertical bone defect, infra-bony pocket. If somebody says these terms in front of you, you should know they're all same. It suggests that the patient may initially have the molar incisor pattern of periodontitis before additional sites become involved, and this pattern indicates that the patient is especially susceptible to periodontal tissue loss, in part as a result of a hyperactive immune response. Although the crowns have good margins, they are in traumatic occlusion, and jiggling forces on closing would increase the mobility of the teeth. So because they're in traumatic occlusion, that can add to the fremitus. Trauma from occlusion can lead to mobility. Now, is this patient suitable for treatment in general practice? Now, the same case, if you imagine yourself in the exam and the same case was presented to you, on the treatment, ADC would be now keen to know how much comes under your expertise and when does the referral is required. So even if you are a periodontist, you would not be thinking in terms of performing the treatment because you are equipped and you think that you're an expert in treating such cases. In the exam, you would be thinking like a general dentist, that this is the scope of a general dentist, and beyond this, I will have to refer to a periodontist. So the severity of the complaint and the age of the patient indicate that there is a predisposition to periodontitis, which may progress even despite the treatment. The initial phases of treatment could be carried out in general dental practice, but some teeth already have a poor prognosis. It's a complex case. Unless you have a special interest or are a specialist in periodontology, the case may be best referred for treatment by a periodontologist. So if given as a choice for such multidisciplinary and complex cases, especially when you have the molar incisor kind of periodontitis, because those are the ones which respond least, or you can say they are the slow responders or have the high rates of recurrences, or maybe the refractory cases. So in those cases, referral should be your best choice. So this should help you answer in the exam as well. In the complex cases, multidisciplinary cases, or in the refractory cases, or in non-responding, especially the molar incisor cases, aggressive periodontitis, rapidly progressing ones, specialist referral is your best choice whenever given. What would you include in your letter of referral? Well, you don't need to really learn all of this. So what care plan would be appropriate? So what should be a treatment of plan even when the periodontist takes it up? The prognosis for the 3 worst affected upper anterior teeth is hopeless because of their loss of bony support, drifting, poor appearance. Additionally, if the teeth were to be saved, they would require new crowns, upper right first molar has furcation involvement, and the bone loss to the apex. It is likely to require either unpredictable complex treatment or extraction. The anterior teeth are symptomless and do not require immediate extraction, but should be extracted in the near future to minimize the risk of attachment loss of adjacent teeth and infections and abscesses, and to improve the appearance. An immediate replacement denture would be the treatment of choice because no definitive restorations can be planned until the periodontitis is brought under control and the long-term prognosis for each tooth is clear. In the mandibular arch, the left lateral has bone loss to the apex, requires extraction. Long-term prognosis for the lower right canine remains to be determined, but at least initially, it is worth taking a conservative approach and assessing the response to initial non-surgical periodontal treatment. Now, the care plan should include first, patient information and education of presenting clinical issues and appropriate and achievable goal setting, planning, self-reflection to help the patient manage the situation in the medium to long term. Then the oral hygiene advice to include instruction in plaque control, toothbrushing, and interdental cleaning. Extraction of hopeless teeth like your both upper centrals, upper right, lower left lateral, and upper right first molar. Immediate replacement prosthesis, which you would give because this is all in a side zone. Root surface debridement of all pockets which are greater than 4 mm under the LA, particularly the lower right canine. Periodontal assessment after 3 months. Memorize the assessment period and the waiting period because ADC loves to ask you about the reassessment after periodontal treatment. They totally love it. They don't want you to forget about the patients after the referral. Regular periodontal maintenance therapy, initially on a 3-monthly basis. Continued care for the remaining dentition, including caries prevention. Extraction of further teeth as required, and then assessment of a permanent prosthetic replacement. This all needs to be done. Patient education, initial conservative therapy, extracting of hopeless teeth, giving an immediate replacement, following up, reassessing, and if at all more teeth are failing, extracting them. Once it has stabilized, giving the final prosthesis, right? That should be the subheading or the subcategories of your major treatment plan. And even if it's going for a referral, you know that you are a primary general dentist, you will always be in touch with the periodontist, and it's your patient, and you will have to need to be part of this entire treatment plan. The details, including the time commitment, cost of treatment, must be discussed with the patient. Patient must be given a written personalized care plan to consider and agree to. The patient indicates that he would rather attempt to preserve the lower right canine than have it extracted, even though there is no guarantee of success. Now, what are the options for an immediate replacement prosthesis in the upper arch? So after the extraction has been done for both the centrals and the lateral here, the possible intermediate or an immediate prosthesis, temporary prosthesis that you can give is either an immediate RPD, acrylic RPD, or an immediate minimal prep bridge like a Maryland bridge, or implant. So immediate removable acrylic denture, which uses your rod stainless steel flask for direct retention, and the denture must be kept clear of gingival margins as much as possible because that can again hamper the periodontal health. Patient already has inadequate oral hygiene, never had a denture before, and once the anterior ridge resorbs and remolds, the denture will not fit, and you might require even the relining of it. So acrylic offers the advantages that you can add in future more teeth if his periodontitis progresses. Apart from that, you can give a Maryland bridge. It is much more complex, success is less predictable, and the span is really long, and occlusion is unfavorable. Well, with implant, with ongoing unstable periodontitis, there is a significant risk of long-term complications like periimplantitis, which will result in failure. Again, success would be unpredictable with the complex techniques required. There is little residual bone, and implants would require some bone grafting or guided tissue regeneration techniques with a membrane placement. Immediate loading implant techniques have a higher risk of aesthetic complications, including a recession, and that's why it would not be recommended. So your best choice is left with immediate acrylic denture. So what are the options for immediate replacement in the lower arch? Again, the same options are your immediate removable acrylic denture, or minimal prepared Maryland bridge, or no replacement at all. So in the lower arch, this is a less advantageous option of removable acrylic denture because a simple partial denture would be relatively bulky for mandible and cannot be designed to avoid the gingival margins. Compared with the upper denture, it would therefore be much more likely to compromise the plaque control and carries the risk of being poorly tolerated. So the better option would be either to go with a cantilever pontic Maryland bridge, which is retained on the central incisor or on the canine. The canine is the obvious choice because it has a better crown to root ratio, but then you will require a maximum wraparound to maximize retention. The quality of lab work will be critical because the restoration cannot be temporized if the fit is not satisfactory. If the immediate replacement does not fit after the extraction, the patient will be left with the gap. In this immediate option, hemostasis and moisture control also will be of critical importance because you will be achieving the retention by using your raisins and dents on the Maryland bridge. The design of the pontic must be optimized to favor the plaque control in view of the patient's susceptibility of periodontitis, and it may, however, be the best option if a replacement is opted. So no replacement. In short term, it is quite possible that patient would accept the appearance of the gap. This would be the best option for periodontal treatment because there would be no plaque, no sites for plaque entrapment, and plus the situation could be reassessed with the prognosis of adjacent teeth. The canine is still prognostically questionable, so the patient opts for an upper immediate removable acrylic denture, extraction of the lower left central incisor, conservative periodontal treatment for the lower canine, completes the total first 8 items of your care plan. No further extractions are necessary. After 6 months, the patient has responded very well to non-surgical periodontal treatment. There has been marked gingival shrinkage around the lower canine, though no bleeding on probing and the pocket depth is 4 millimeters. Excellent response to treatment is, of course, largely the result of the effort of your hygienist or hygiene therapist who has motivated and educated the patient and performed the treatment. The patient is managing with the denture but dislikes it. It is now becoming less retentive because, of course, the alveolar ridge is remolding and reshaping, and anterior teeth have dropped on a couple of occasions. He would very much like to discuss now a permanent replacement. The lower arch is now stable after periodontal treatment. The appearances of the patient's mouth after his initial treatment are shown in the pictures. Bone levels around the remaining teeth are similar to what they were on presentation, given in the picture 54.4. So what are the options for definite treatment? So now, because all the periodontal treatment went really well, you understand the sequence of treatment planning, you go with the education, you go with removing of hopeless teeth, giving a conservative periodontal therapy, and then maintenance of it, removing more teeth if they show their prognosis, and giving an intermediate, immediate replacement option, and then going for your permanent replacement option. So before you decide the definite treatment, the definite prosthesis, the management of periodontitis is clear for everyone, I hope, right? The steps that take. And you see how prosto and perio go hand in hand here. You can't, your prosto selection, your prosthesis selection has to be meticulous, has to keep in mind the existing periodontal problems and how it can affect the future of periodontitis here. Now going on to the last step, which is the definite treatment after stabilizing the disease. First, a fixed bridge. Well, this would be possible, but there are some difficulties. One, and that is a very, very important concept, which you have read in prosto files with me. You have done this concept. We have seen the reference. We know this. So extensive bone loss from periodontitis has resulted in marked shrinkage of the ridge after extraction. And when you can actually put a finger on that concept that I'm talking about, just give me a hug that yes, you remember that. We have done this, we have seen the reference, and you know it, right? So extensive bone loss from periodontitis has resulted in a marked shrinkage of ridge after extraction. This would make the pontic to be placed more palatally than would be ideal. If this in combination with a high lip line and the reduced lip support can make the appearance of a bridge less than ideal, and this would be overcome by the removable prosthesis with a labial flange. So does that make you think of the concept and the question that we have done before? What will help you decide between a fixed prosthesis and the one with labial flange? If that rings some bell, pat yourself on your back because you have done it and you remember it. That's perfect. Now the span is long, and one of the abutment teeth is a lateral incisor. It is understood, but lateral incisors are never abutments of choice because of their small root, concordial dentine, and angulation. In addition, picture shows that there is bone loss at least till half of the root length. So although this tooth is currently stable, but doubts about long-term maintenance persist, and this tooth is not suitable to take the load required of the bridge abutment. Even if the adjacent canine were prepared as well, if a bridge were to be provided, it might be wiser to extract the compromised upper left lateral also, and then give a fixed bridge by using both canines as abutments. It would give you better control of the appearance. Had the tooth been less compromised, it might have been even included in a double abutment with the canine, but a bridge would also involve considerable expense. And if the double abutment is used, there is significant risk of failure of cement lute on the lateral incisor. This would be difficult to diagnose because the bridge would remain stable and would lead to caries. The double abutment bridge design is no longer recommended. Because of the various different kinds of forces acting on these two different abutments, on the lateral and canine, one can lose the cement lute. And then if one can lose it and the other would remain steady, and that's why the patient would not know that it's a loose bridge. And that's why that gap between the cement lute loss in the lateral would become site for plaque entrapment and would lead to secondary caries. Then implant would be another fixed option, but an implant retained bridge is possible. Periodontitis would need to be fully treated and the patient's tooth condition stabilized and maintained. Bone graft would be necessary for ideal placement of implant and the pontic. Then new permanent removable acrylic prosthesis, right? You can go ahead with a complete new permanent acrylic RPD. If the periodontitis was not controlled by the patient, or if there were more teeth with questionable prognosis, a replacement denture with a major connector constructed from acrylic resin could be considered. This prosthesis would derive some support from the rest on the cingula of the canines and by covering the vault of the palate. Now, what we read further from here would be the concepts of your minor connectors, your major connectors, your rest teeth, your clasp assemblies, direct retainers, and indirect retainers that I have taught you all in your prosto class. So keep giving me a heads up if I call for those concepts and you can memorize them, because that is a good review point of all those concepts, right? So now this prosthesis would derive the support from the rest. So we know that support comes from your rest or your distal extension acrylic component, right? And teeth with uncertain prognosis could be added later. So what is the benefit of giving an acrylic RPD over the cobalt chrome? Well, if the teeth have questionable prognosis, you can add more teeth. Do we remember that? Then clasp of either wrought stainless steel or gold could be used on these teeth with a favorable prognosis. Coming to your removable prosthesis with chrome cobalt framework. So in the exam, if you get an unstable periodontal condition, but they ask you the permanent solution, go with your acrylic permanent RPD, right? And the benefit of that is that it can be easily relined. It has the ease of adding teeth. Removable prosthesis with chrome cobalt framework, and that is by design, by functionality, the best. This is the best option. It is less expensive than a bridge or implant, much simpler, can be designed to favor the oral hygiene procedures, and addition of further teeth in the future. So although it is difficult to add teeth to chrome cobalt, but if you keep it in mind that some teeth may be lost and you design the RPD framework initially keeping that in mind, then you can add teeth in the future to the metal framework RPD. Only if you have not kept them in mind, then you cannot add the metal framework to it, right? So further teeth can still be added to chrome cobalt as well, but you have to keep them in mind and design the framework as well. Patient was very happy with the appearance of acrylic partial denture, found it very well retained until recently. However, after discussing the options, he goes for chrome cobalt based RPD. An additional factor not visible in the figures is that lower incisor has also over erupted as a result of drifting of the upper teeth. The occlusion also makes the option of bridge unattainable without adjustment of the lower incisor. So in that case also, your RPD would be super beneficial. So who should design the prosthesis, you or the lab, and why? Well, the design of any denture has to be a team effort between the you and lab, so you don't really have to go into these details. Could you refer to the patient? Also not important. Now, the important part here is the designing part, right? This gray box is really good and important, and you have also learned all these concepts in the prosto file. We have discussed this thoroughly while doing RPD. So first, determine what teeth are to be replaced, outline the saddles, and please remember, even your part 2 examination would require you to know the RPD design. So this is not just for your paper 1 preparation, part 1 preparation, but also goes on along with you till your part 2. So you outline wherever the teeth need to be replaced and the saddles, the distal extensions, then plan the support for the denture. Where would the support come from? Is the denture going to be tooth supported, tooth and tissue supported, or just simply tissue supported? Then plan the path of insertion on the surveyor, identify the guiding planes, consider their preparation. Because this patient has lost the anterior teeth and has a high lip line, the anterior acrylic flange has to conform closely with the soft tissues, so the model may have to tilt the posterior teeth on the surveyor table. Then plan direct retention. The clasp assembly gives you the direct retention, which is provided with the clasp. You can give and engage 0.25 millimeter of the undercut with your chrome cobalt clasp if it's occlusively approaching. If it was an I-bar clasp or a gingival approaching clasp, you can engage 0.5 millimeter. If I remember these values, we have done that. I've shared the reference also before. Now, is there adequate direct retention, or will you have to provide indirect retention? You have now read the indirect retention principle as well, and how you can give auxiliary rest to prevent the vertical upliftment of the denture against the vertical forces, right? So consider major and minor connectors as well. These together with proper base extension will give you stability against the lateral and anteroposterior displacing forces. So stability is against horizontal forces, retention is against vertical forces. Remember that. Advantages of different connectors are given, which we have already discussed in the file. You can go on and look at that table. Then review design for three aspects: simplicity, biological acceptability, and appearance. Is as much gingival tissue as possible left uncovered? Are there unsightly anterior clasp or prominent occlusal rests that are really unnecessary? What tooth preparation is required? This may include rest preparation, ideally modifying the profile of existing restorations on the teeth, adding composite resin, preparing guiding planes, altering the height of survey lines to allow correctly constructed clasp. Right? So all this tooth preparation criteria also is assessed and judged. Final design is shown in the picture. What are the design features in this particular case? So you look at this picture here. So this is the antero-posterior bar kind of major connector, and this is your pontic. This posterior pontic is also given to replace the missing molar space. If you see now, this is your clasp assembly on premolar, a clasp assembly on the molar. Here the clasp assembly is given again on the molar, and there are rests provided on this canine, and the lateral. So there are rests, and the minor connector is the one which connects the rest of the parts to the major connector. So these are the minor connectors. Minor connectors, instead of crossing the interdental papilla, is rather crossing through your middle part of the palatal gingiva. So it also prevents the impingement of interdental papilla. So now let's talk about in detail about this design. The path of insertion was determined by the soft tissue profile of the anterior edentulous saddle. When a large labial undercut is present, model must be tilted down during surveying to ensure that the flange fits well and has the best possible appearance. Support was derived from the rest which was given on the canine, the premolar, the first molar, left lateral, canine, and your first molar. This is probably more than necessary, but the design has not become overcomplicated. Rest on the left canine is necessary in case you later extract the left lateral incisor. Without it, the denture will have no left anterior support after the extraction, so it could have been a failure. But because you have kept that design in mind and you have given rest on both lateral and canine now, so in future, if you extract this lateral, the canine would still have the anterior support, and this can be easily replaced by adding the tooth, acrylic tooth. So this designing or keeping the future in mind would save the patient another prosthesis. This demonstrates the importance of planning for possible failure and also the need for good communication between the lab and technician. The rest of the canine, this rest of the canine might not have been included otherwise. Otherwise, the lab would think that it's not required on both these teeth, just on lateral would be enough. Now, direct retention was provided by the cast cobalt chrome occlusally approaching clasp placed on the posterior teeth because of the patient's high smile line. The clasp face into the main saddle. However, the recurved clasp on the upper right premolar is still visible. The clasp tips are placed in undercuts relative to the path of insertion. There is sufficient direct retention, so no indirect retention was necessary. And mostly, the indirect retention is used preferably for distal extensions. The chances of lifting up of your acrylic distal extension is higher. That's why it requires indirect retention. Here, the direct retention suffices on both sides, anteriorly also. So indirect retention is not required. The pontic design chosen for the upper right molar was metal sanitary pontic, this one. Use of a sanitary pontic has avoided placing the metal tagging and an acrylic tooth in this periodontally vulnerable interdental area. Now, what is the indirect retention and why is not required for this denture? Again, I have elaborately given you the mechanism, the principle of indirect retention, and how it is helpful in retaining your distal extension RPDs. If partial denture has two clasps, the denture will tend to rotate away from the soft tissues about an axis between two clasps. So the fulcrum, imaginary fulcrum line going between from the most two distal direct clasp assemblies can lead to the rotation of the denture away from the supporting tissues. Indirect retention is provided by a rigid component which is placed on the teeth opposite the saddle such that the saddle will not rotate away from the ridges. Indirect retention is usually required for your distal extensions and in Kennedy class 4 kind situations where direct retention from anterior clasp at each end of the saddle would be unsightly. In a single free end saddle situation, the denture will rotate around the distal clasp and the rest must be placed on the tooth opposite the saddle and as far as possible from the axis of rotation. In the present case, direct retention from the clasp is sufficient. Well, there were no medical legal issues raised in this case. However, there could have been some concerns like the clasp visible or why this periodontal disease was not diagnosed by the previous dentist, but he did not raise any such legal concerns. Right? The final result in this case was a restoration that the patient was delighted with and one that you should be pleased with. The posterior clasp is visible, but the overall result is excellent. This case effectively illustrates how a relatively simple care plan procedure produces the most predictable result. And what we learned from this for the exam is ADC loves cobalt chrome RPDs. You learn a lot of principles here for designing. ADC loves periodontitis and effect of prosthesis on it, and the assessment and the periodic evaluation and choosing the best prosthesis for such patients. So this is in fact the core of what ADC serves you the SPQs as in your paper 2 and in paper 4. This chapter would help you answering a lot of questions, not just in paper 2 prosto, but also in paper 4 with periodontitis. Okay, so now we begin with case 62, and it is also important to the extent that periapical segmental dysplasia is frequently asked as MCQs in the exam a lot. Like especially in paper 3, we've done the oral medicine file, the osseous lesions, periapical segmental dysplasia, or the florid kind, and even the radiological findings of it in radio also. So in paper 4 also, some radiographic observations or diagnosis could be asked related to this condition. But it's a very sweet and simple, very easily identifiable lesion. There's nothing very complicated about it. Simple investigations and methods would lead to simple diagnosis. And even the treatment part is not too complicated, usually requires no treatment and observation. So let's start with it and see how it goes with it. So 36-year-old Nigerian woman presents at your practice for the first time complaining of toothache. This is a periapical radiograph of both lower left premolars and the first molar. What you see here is some periapical radiolucency associated with the molar as well as the premolar. There is this radiobasity also within the radiolucency along with the first premolar. Now the patient complains of toothache associated with her lower left teeth, points somewhat imprecisely to the lower left quadrant. So that pain is poorly localized. She cannot precisely tell which tooth it's coming from. So history of complaint is the patient has been aware of intermittent pain at the site for several months. Initially, the pain was short-lived and brought on by hot and cold rings. But in the last few days, the discomfort has become progressively worse. She's now suffering a fairly constant and a very painful toothache that is no longer closely related to hot and cold stimuli. Now, it does actually sound like a pulpitis pain history because it was there intermittently for several months. Then initially it was short duration and which was actually brought on by stimulus of hot and cold. In the last few days, it has become worse and now suffers fairly constantly. So it is not stimulated but spontaneously or constantly there. And a very painful toothache that does not links with the hot and cold stimuli anymore. So it has become spontaneous. That kinds of takes you from the reversible pulpitis towards the irreversible pulpitis. And because it is poorly localized yet, so we know that early stages of irreversible pulpitis are fairly poorly localized. PDL has not yet involved, and most of the pulp still remains partially vital. So she's otherwise fit and well, and no positive findings are revealed by the medical history. Now, she's a fit and healthy looking African woman. The submandibular lymph nodes are not palpable. There is no detectable soft tissue swelling, and the TM joint appears normal. Upon intraoral examination, the lower left second premolar and first and second permanent molars are heavily restored. There is only a small restoration in the first premolar. Several other teeth contain smaller restorations. Surrounding oral mucosa appears normal, and there is no bony enlargement or swelling. No tenderness is elicited on the palpation of lingual or buccal sulcus adjacent to the teeth, and contour of tissues appears normal. So, endodontically speaking, the palpation does give you the estimate of the pulp status, that whether endodontic involvement of the pulp has now spread towards the periapical area. If the palpation resulted pain and tenderness, that would indicate an abscess or periodontitis in the area. So how would you interpret the history and the examination results so far? Well, the clear history of toothache, which is normally correctly identified by the patients, and the large restoration suggests that one or more teeth is giving you pulpal pain, probably as a result of caries or complications of restoration. The pain is poorly localized, severe, feels like toothache, and has been exacerbated by hot and cold in past, almost certainly indicates pulpitis. The recent onset of the pain unrelated to the stimulus now suggests that it is late or irreversible pulpitis, but that the causative pulp still remains partially vital. And that is why it has still poorly localized. It has not completely devitalized or necrosed, because once necrosis set in, then it becomes poorly, well localized, because the PDL gets involved. Now, the history does not suggest the spread of infection or inflammation in the PDL, which is normally would be elicited by pain on biting and accurate localization of the positive tooth by the patient. So if the PDL was involved, that would be a well localized tooth and pain. Now, what simple additional examinations would you perform and why? So all the teeth in the lower left quadrant, distal to including the canine, should be percussed. The same teeth should be tested for vitality together with the equivalent lower right teeth for comparison, provided there are no clinical features like caries or restorations suggesting that these teeth may also have compromised vitality. Now, when this was done, it is found that no teeth were particularly tender to percussion. Both the second premolar and the first molar might be slightly tender. Patient is unclear, so that means poorly localized, but neither gives a dull percussive note. Second premolar is vital. Then the first molar is slightly hypersensitive, both by your EPT and your fold test. Neither test causing acute pain. So there is some hypersensitivity. Now, investigations. What investigations would you now want to take and why? So an intraoral IOPA of lower left premolars and first molar should be taken. So far, the examination indicates that the first molar is the most likely cause because of the result on the pulp test. However, the patient is vague as to whether the second premolar is tended to percussion or not, and it contains also a large restoration. So either the second premolar or the first molar would be the source of the pain. A radiograph cannot provide direct evidence of vitality. However, it will provide information on the possible cause of loss of vitality, like secondary caries under these restorations, inadequate restorations, as well as revealing previous attempted RCTs or periapical abscesses or granulomas. And a radiograph will also be required in the event that extraction or RCT is necessary for any of these two. So periapical radiograph was shown, and you see the radiolucencies under the premolars and the molars. So there's a small restoration in the first premolar, large restoration in the second premolar and the first and second molars. No evidence of dental caries. Early bifurcation bone loss associated with the first molar. Radiolucent area that is centered on the apex of second premolar appears to extend to involve mesial root of the first molar. Loss of lamina dura around the apex of the root of second premolar and the first molar mesial root, and a well-defined radio opacity close to your first premolar root. So what would you do next and why? Further radiographic views are required. Radiograph has not aided diagnosis of the dental pain because no unsuspected cause for pulpitis has been identified. However, it has revealed an apical radiolucency on the second premolar and the first premolar, and this is not compatible with the uncomplicated periapical granuloma infection or cyst. The presence of apical radiolucency on second premolar is also incompatible with the history and exam results, which indicates that this tooth is vital. The presence of both radioopacity and radiolucency requires consideration of a wider differential diagnosis, which will include the fibrocemento-osseous lesions, and also some of the odontogenic tumors, other variety of bone disorders. Now, this is a part of your OPG where you see that radiolucency, which was surrounding the premolars, it is diffuse radiolucency, has centers of radioopacity, and it is actually on the other side of the jaw also, involving the second premolar and the molar area on the right side, along with the affected your first premolar, along with the anterior teeth. So it's a mixed radiodensity lesion. It is radioopacity surrounded by radiolucency. So you can see the margins of the radiolucent lesions are not visible on the radiograph and need to be defined more. That is why you require an OPG, right? And these will also allow all the teeth and supporting structures to be assessed because the patient is being seen in the practice for the first time. Bite wings to assess caries would also be appropriate in a new patient which has severely heavily restored dentition. So some part of OPG is shown. What do you see? So we see there is absent lower right second premolar and the first premolar and presumed extracted. A small occlusion restoration in the lower left second molar, which has tipped slightly mesily. Extensive lesion of mixed radiodensity involving the central body of mandible from mesial root of the second molar across the midline and joins the previously shown defect on the left. Lesion appears to be composed of several radiolucencies, central radiopacities centered on the root apices. Little or no expansion of the bone despite the extensive lesions, and lesions are not even displacing the teeth or the inferior dental nerve canal. So the differential diagnosis of such mixed radiolucency would be primarily your periapical segmento-osseous dysplasias, which can be periapical, focal type, or florid type. And chronic osteomyelitis also gives you mixed radiolucency. Paget's disease of bone also gives you sometimes spot and wool occurrence, mixed radiodensities. Fibrous dysplasia, metastatic malignancy. Now, what is the most likely amongst these and which one can be easily excluded? So the most likely one is segmento-osseous dysplasia. It's the most likely cause of patient's jaw lesions. The patient's racial category, also ethnic group, also is at higher risk of periapical or segmento-osseous dysplasias. The diagnosis may be made on even the radiographic appearances alone. No other condition gives you multiple lesions centered on the apices of teeth, each with a central radiopacity and a variable and poorly defined radiolucent trim. As disease progresses, this pattern can become less distinct, but it is clearly visible in several of this patient's lesions. This patient has a florid form. Florid form means more than multiple teeth and more than one quadrants getting affected. Periapical form affects few teeth, usually the lower incisors, and the focal form gives rise to one large lesion. But they all are part of spectrum of same disease and it only varies in severity. The diagnosis is supported by the patient's race. These conditions are more prevalent in African and Mongoloid races. The lesions are normally asymptomatic. Now, which can be easily excluded? Why? So chronic osteomyelitis produces again a patchy mixed radiolucency, but will show symptom of dull, boring central bone pain, which is quite distinct from the one which is reported. Sinuses or other signs of infection would be present. However, this diagnosis should not be completely excluded without further consideration because the sclerotic bone or fibrous cementoosseous lesions such as florid kind is also prone to infection, particularly the dental infection. And in the past, the condition was thought to be a form of osteomyelitis because it can get supra-infected, and this periapical cemental or the florid kind cementoosseous dysplasia can get infected and can develop osteomyelitis, right? So a biopsy to confirm the diagnosis is contraindicated because even the biopsy can risk the initiation of osteomyelitis. And that is why here the diagnosis would be confirmed on radiographic and clinical findings alone. Paget's disease of bone can be also excluded because that rarely affects mandible and mostly seen in maxilla. And Paget's disease affects predominantly Caucasians and in their 40s or 50s, older ones. Then the fibrous dysplasia can also give you patchy, poorly defined mixed radiodensity appearance, but they also affect usually maxilla and young patients, usually the first or second decade of life. And metastatic malignancy, usually seen, as I've also discussed with your medicine file, they would be seen in the posterior angle region of the mandible and would be your purely radiolucency and would be a metastatic lesion coming from prostate or breast cancers and would have a sun ray radiopacity, sunburst pattern. Right, but the site is not correlating with the metastatic malignancy site, which is mostly linked with your posterior angle of the mandible region. And radiological appearances are sufficiently characteristic of florid kind cementoosseous dysplasia, and you can exclude this sinister diagnosis. Now, how might you confirm the diagnosis without biopsy? So, any previous radiographs, if they can be reviewed to determine whether the lesion has been present and slowly progressed over several years, that will totally confirm your diagnosis. And the previous dentist was contacted, and you can find an OPG which was taken 11 years back, the section of which is shown here, and there is a radiolucency and the radio-opaque patch, radio-opacity line between. So the radiograph shows the lower left quadrant, lowest second premolar and the first molar contains smaller restorations than at present, and there is probable caries in the second premolar. However, the first premolar appears to contain the same restoration as present, and its apex there is a lesion typical of early cementoosseous dysplasia, comprising radiolucency with central opacity at the root apex. This early stage of the lesion is providing enough conclusive evidence for the proposed diagnosis. So what should be done about the patient's pain, which was correlating with pulpitis? Well, then the causative tooth must be properly identified, and in this patient, EPT suggested the first molar is to be blamed. Increased sensitivity on EPT and cold testing may be explained by the presence of pulpitis or small vital pulp remnants in otherwise normal pulp. When pulp tests fail to identify a cause, the most effective method is test cavity without LA, the most likely to. Now, this is not possible in a tooth with acute pulpitis, but works well in the case of low-grade pain if a pulp is completely or partially viable, or when the patient's response to testing cannot be relied upon. Alternatively, a diagnostic LA injection can be given to abolish the pain, but usually it will not work for your mandibular first molars because a block would be required to achieve effective analgesia. Once the anesthetic is given, you will not be also able to perform any further pulp test at this visit. So you perform a test cavity, first molar was found to be non-vital with vital pulp in only one canal. Either RCT or extraction was required. So what about the pictoradiolucency on the second premolar? Well, this was another early lesion of cementoosseous dysplasia. Some years later, radiographs revealed that the lesion has developed a zone of radiopacity centrally. Now, does florid cementoosseous dysplasia have any significant complications? Well, yes. We also discussed that before, that precautions must be taken to ensure that they do not develop osteomyelitis in the sclerotic bone of the mandible. A regime for prevention of caries and periodontal disease must be instituted to reduce the risk of any future dental infection. In this patient, periodontal condition of the first molar was poor, so extraction was preferred option. Other non-vital teeth should also be extracted if there are reasons to suspect that RCT may not be successful. Antibiotics should be prescribed during the healing period for all extractions, so you may count them as immune compromised or at risk of developing severe infection. So in this case, antibiotic coverage may be considered for extractions or any other surgery. And they should be performed best in hospital rather than in general practice because that can lead to the risk of exposure to infection and development of osteomyelitis. So things to learn here would be identification of your cemental dysplasia, which would be the mixed radiodensities, knowing the race, African and Mongoloid patients are mostly afflicted with them. Then also the teeth and the mandible area, which would be vital, would be affected. It is asymptomatic, not much treatment is required other than observation. Other dental infection sources should be removed to prevent any formation of osteomyelitis. Right? I think not a very complicated case, short and sweet, but gives you some opens up your mind to the differential diagnosis of the mixed radiodensity kind of radiographic findings. So case number 65, failed endodontic treatment. A 17-year-old female patient presents to you with apical infection on a root-treated maxillary first molar. What are the treatment options and their chances of success? The patient points to her upper left molar, reports that it is tender on biting. The tenderness on biting developed about 4 months ago. The patient has always attended regularly for dental treatment, and RCT had been carried out 2 years ago. Patient is otherwise medically fit and well. TM joint appears normal, and no submental or submandibular or cervical lymph nodes are palpable. Patient presents with an otherwise unrestored dentition. Permanent upper left first molar has been restored with a large occlusal raise and composite restoration. What investigations would you carry out and why? So upon periodontal examination, including the recording of probing depths and gingival bleeding, a wider pocket that can be probed to the apex would indicate a localized periodontal defect, and that can indicate a probable endodontic periodontal lesion. And if it's a localized deep pocket, it would also raise a suspicion of a vertical root fracture. And also checking the marginal integrity of the raising composite restoration by gently drawing a smaller straight ball-ended probe along and across the filling and tooth interface without pressing, because it can cavitate an incipient carious lesion. Checking the mobility of the upper teeth, and increased mobility, especially in this first molar, would suggest the presence of periapical abscess. Palpation around the apices would suggest presence of acute apical periodontitis. Now, on performing these investigations, you find that the upper left first molar is more tender to percussion, slightly more mobile compared with the adjacent and contralateral healthy teeth. Radiographic examination of the upper left molar was done, and periapical radiographs, ideally which were taken by using the paralleling technique and a beam aiming device, are required because it would give you the presence and quality of the root fillings, status of the periradicular tissues. It will help in identifying the source of the sinus, detect or exclude caries, help eliminate root fracture as a cause. This is difficult as the fracture line would have to be in the line of X-ray beam to be visible, and even then might be superimposed on the root canal or root filling. Then you can confirm the alveolar bone levels. CBCT can be done with high resolution. It would be useful in complex retreatments of upper molars. It will help you in assessment of presence of additional roots and canals, assess the presence of unexpected curvatures, excluding endoperio involvement, and to establish if a reactionary thickening of the mucosa of sinus is present. The periapical radiograph and CBCT images are shown. What do you see? So this is your periapical radiograph, where you can see that the palatal root shows the periapical radiolucency, but it's not so much. It is mostly confined within the PDL. Looks like more like a widened PDL. Also on the mesiobuccal root. The discobuccal root has been superimposed by your zygoma, and also the radiolucency is the maxillary sinus. It is a CT scan here, and it shows that there is far more radiolucency than was evident on the IOPA. Even if you look at this from the buccal aspect, then this radiolucency is surrounding your buccal root as well. Here both mesiobuccal and distobuccal roots are seen. So it's involving both your mesiobuccal and distobuccal roots, which was not evident on the IOPA. And this radiolucency is more than what was evident on the IOPA. So upper left first molar IOPA shows that there is a defective root canal obturation, which appears to be short of the apex in mesial and distal root. They are not well condensed in palatal root. A large apical radiolucency appears to be associated with mesial and palatal root of the upper left first molar. On CBCT, you find that the radiolucency is also associated with the distal root, and radiolucency with the palatal root is limited in size. There is no evidence of associated inflammation of maxillary sinus. So what would be your treatment? This retreatment case does not present particularly difficult challenges, both on the periapical radiograph and on the CBCT. The lumen of the canals is clearly visible beyond the root filling, suggested that the canal has not been blocked by the dentine. And the CBCT image clearly shows the distance between the pulpal floor and furcation is at least 5 to 6 mm, which ensures safe removal of the resin composite restorative material, which clearly reaches the pulpal floor, minimizing the risk of perforation at the furcation area. It can be removed coronally by using high-speed burrs, and in the deeper part of the pulp chamber by using dedicated ultrasonic tips, which will aid in selective, minimally invasive removal of the material. Once a provisional working length has been established by using the PA radiograph or the CBCT image, the GP is removed gently by softening it by drop of chloroform or other solvent by using your headstrong files, number 25 or 30, or your super flexible nitrile files in reciprocation. Now, it is essential not to engage your headstrong files in the curves of the canal because they can get easily separated. The provisional working length is essential to prevent extrusion of GP into the periapical areas while attempting to remove it. This is a risk which is relevant clinically, especially when the obturation is close to the larger apices. Once the existing canal obturating material has been removed, it is essential to identify the orifice of a second mesiobuccal canal. Now, this is 1 year periapical radiograph and the CBCT after the retreatment. What do you see? So in this instance, CBCT shows that healing is not as complete as it appears in the IOPA. If you look at the IOPA, it looks like a well-filled canal. You also see a MB2 has been filled along with the MB1, but the periapical area looks completely healed here. But if you look at the CT scan, then you see that there is still some radiolucency surrounding the root, mesiobuccal here as well. And here you see this is MB1 and this is MB2, and MB2 meets the MB1 at the level of confluence, so it is well obturated canal now. It is important to protect the cusp of the upper left first molar with some metal or ceramic onlay to prevent the fracture of the tooth. Further recall in 1 year is indicated to confirm the complete healing. Now, findings from the periapical and CBCT after 1 year of the recall. The upper left first molar shows complete healing on the IOPA, but whereas on the CBCT, it shows incomplete healing of the buccal roots, whereas the coronal view shows that a second mesiobuccal canal has been correctly obturated up to the level of its confluence with the first mesiobuccal canal, which we could appreciate here on this view. And that would be it. Thank you so much.